Welcome to the Interventional Glaucoma podcast, brought to you by Elios. Join us for unscripted discussions about the latest innovations in interventional glaucoma with leading ophthalmologists in the field.
Welcome everybody to another episode of Interventional Glaucoma podcast series. Today we are posing the very difficult question of, are patients really happy after glaucoma surgery? I'm delighted to be joined by three amazing guests and good friends, Karl, Jose, and Anna. Welcome, guys. Thank you for joining us today.
Thank you.
Thanks.
Hi.
So, between the three of you guys, you have a wealth of experience of happy patients. And unfortunately, over a career, we also have unhappy patients. And I think in today's podcast, we'll try to delve and decipher how we can tread that fine line to ensure that we have as many happy patients as possible. As the saying goes, happy wife, happy life. I think for us, it's probably even more pertinent that happy patient, happy life. So let's explore a little bit into what makes patients happy, and are there typical profiles or characteristics of patients that should point us towards certain procedures, outcomes, or treatments. We talk about wanting happy patients, but what do we really mean by that? What is the definition of a happy patient to you, Karl?
Yes, Gok, it's a good question, isn't it? For me, the happy patient in my glaucoma clinic needs two essential things. One, reassurance that their glaucoma is not going to make them blind or give them any form of visual disability, i.e. they can keep on driving, they can keep on going with their normal lives. And that's crucial, isn't it? But also, keeping them happy also means that whatever treatment is necessary or we choose for them to achieve that primary goal also ideally prevents them from having side effects or problems. And as we know, any choice we do or take can give patient problems. So this is always the issue, if you want, or the challenge of us glaucoma guys, isn't it, in the clinic? Because we're treating an asymptomatic disease, and we have to make choices and ask the patient to trust us to make the right choices for them.
Yes. And I guess, Jose,
Absolutely.
going onto that, what we think makes the patient happy may be very different to what the patient thinks is happy. So we've performed a surgery, a trabeculectomy. The patient has a pressure of 8, and we are very happy. But that patient is not happy. They may have some concerns regarding their vision or the comfort of their eyes. How do we sort of tread that fine line between what we feel would make the patient happy, or our perception of that, versus what the patient feels?
I think that's an excellent question. The thing is, when when you all chose to dedicate your lives to glaucoma, do you really think that was the part of the ophthalmology that makes patients happier than other parts of the ophthalmology? I'm a bit older than all you, and I think that everything has moved and has changed in the last probably 40 years, but recently, in the last 10 years, we have different treatments, different choices for our patients. And I think that right now, we're starting to have happier patients with the new treatments, and we are starting to be happy surgeons as well, because for the first time in glaucoma surgery, we have treatments that after the treatment, the patients are much better than they were before the surgery.
So asking a slightly different question, Jose, when you were starting glaucoma practice and glaucoma surgery, what was the typical mindset or personality of the glaucoma surgeon? Because you paint a bleak picture.
Oh, I think that we were very conservative about trying to indicate surgery. We probably indicate indicated surgery just in very severe cases of glaucoma, in which you knew for certain that it was doing surgery or the patient was going to be blind. And probably now that we have safer surgeries, we are probably more prone to advise the patient for a safer procedure and doing surgery for them in earlier stages of the disease. And probably that has changed a lot in the last 10 years, maybe because of the introduction of the mixed concept.
I think there's no better time to be a glaucoma surgeon. Anna, one metric which is not really going to be something that we can measure or publish is high fives and hugs in the clinic rooms. So how do you measure patient happiness in your practice?
Yeah, that's a very good question. There are smiles already. First thing, their smiles are increasing. But this is such an important question on patient happiness because, you're a surgeon, I'm a surgeon, we're always thinking of surgical success. And I had the biggest hit was when 8 years ago, a lady that I prevented blindness because she was with a very advanced opening of glaucoma, IOPs of 36 under 3 classes. I performed the trabeculectomy, and her IOP was after always between 9 and 11. And I was very, very happy in calling it a success. But the patient was unhappy because her vision had decreased from 10 out of 10 to 9 out of 10. So she finally asked me, if this is a success, why am I seeing less? So this was the first time it really struck me. As we are surgeons, we think of surgical success, but we need to think more of patients' happiness. So we need to take more into account, first communicate with them, then take into account what are their worries and their fears. Second, try to understand their quality of life. We should prevent the quality of life decreasing. So we need to understand what is their quality of life. I have an application that regularly sends them SMSs with quality of life questionnaires, VQF, and it's interesting to know. Otherwise, we can, more than their smile when we arrive, just ask them, how are you doing? How do you feel your disease is impacting you? What are your worries for the future? Just have to take time to listen to the patients and really understand what it worries them. Because we're at the end of the day, we're there to prevent blindness from happening, but we also need them to be compliant and to understand what we want, and we need to understand them. So the relationship, if the surgeon is happy, the patient is not, this goes two ways. This cannot be a one-way relationship.
Yeah, and that's amazing that you collect that data and keep us updated on that. That's a great piece of work. How about you, Karl? We really do want our patients to do well and be happy. Why do we, yes, there is more evidence coming out about quality of life and patient satisfaction, but why doesn't an average surgeon still collect that routinely? What stops us?
Time, forgetfulness. I think Anna pressed on a really important point, communication. So I think that few minutes time we have with our patients in the busy clinic is so precious. And it's not just precious to, do the tests we need to do, but also speak to them about what the expectations are. We need to be honest of what to expect after the surgery. But if you communicate well enough, then the patient has realistic expectations of that. So I think that is key, even finding those extra minutes. And if it requires a digital app, a written questionnaire, printed information, there's various methods to do it. But ultimately, I do think time is our enemy. And I'm guilty myself, of sometimes not finding that time or being too much enveloped in the other stuff around me to forget how important this is. So I think that's the bottom line.
I think you raised several great points there, Karl. One was obviously the introduction of MIGS, the fact that we combine a lot of this with cataract surgery. Do you think our focus, looking more at patient happiness, quality of life, coincides with the advent of MIGS? You know, is it because now we have these options that we're looking at it before, or do you think that we always were, or it's just a lot more prominent now with the clear availability of MIGS?
So I think we are more aware as doctors of it. Patients are more aware of it. And I think there's this whole drive, and all of us here in this podcast today are in our respective countries and clinics and regions drivers for this. So we are more aware of it, and that's the way it is, and I think that's the way it will keep on going, because as we said again, we have so many more options now, and not everyone will benefit from a MIGS. Of course, some patients will come to us too late and will need the bigger surgeries. We mentioned deep sclerectomy, we mentioned TRAPS. And once again, it's about the expectations, but also trying to minimize problems that they have, whether that's quality of life, that one line drop in vision. And sometimes that is achievable by, again, making sure that whatever option you choose is the safest, is the one that might give that patient that little bit extra result, even when it comes to quality of life, which is very difficult to measure, however. We know that, especially qualitatively. I mean, it is difficult.
Jose, how much of this improved quality of life that we see in modern glaucoma practice is attributable to the fact that we're taking out so many more cataracts in combination with the surgeries?
I think that we're really doing by combining cataract surgery and MIGS is, first of all, we're treating a condition that probably worries more the patient than the cataract itself. If you just tell the patient that you're going to treat the cataract, of course, he's going to be happy because the vision is going to be much better. But if you tell the patient that you're going to treat the glaucoma at the same time, the patient feels more relief. I think that they feel that it's going to be something else that might prevent them to use the drops afterwards, which is something very good for them. I always try to explain that, of course, this is not a definitive treatment of glaucoma. I wish I could, cure glaucoma. We have to explain very well that this is not something that is going to get rid of glaucoma forever. But the thing that you're telling the patient that you're treating both conditions at the same time, and the risks are going to be the same exactly as the cataract surgery risks, that makes the patient, trust you and go for the surgery with hopes that he's going to end using drops, at least for a while. So I think that something that really helps the patient to face the disease in a different way. I'm a bit concerned as well. I'm also very concerned about mental health issues with glaucoma. And glaucoma causes anxiety and depression. I think that's something that we should look for, not only to improve the quality of life, but also the mental health issues with the patients.
No, I think you're right. I think we're obviously a lot of the focus on this podcast episode has been about improving quality of life of our patients. But as a general, once you have a diagnosis of glaucoma, we know from studies as well as our real world experience that this has a really significant impact in a negative way on their quality of life. So in a way, the interventional glaucoma mindset, us trying to get patients less dependent on drops, is trying to slow that potentially inevitable downward spiral of a diagnosis of glaucoma that can have on some patients, not all patients, of course. Anna, when you talk about quality of life and the potential improvements that our modern treatments have, how much focus do you put on the control of the glaucoma versus the benefits of being on less or no medications?
This is also a very important question, not only in terms of managing expectations for not only for managing expectations, but also to communicate properly with the patient. What can the patient expect from this surgery, and what are the alternatives and risks and advantages? And when the glaucoma is advanced or there's very high IOP, we need to be more aggressive with the treatment. So this is known. And when the disease is more controlled, or when we have a mild, moderate glaucoma, not advancing, not progressing, and a cataract, we have many other options. So we can give them to our patients and let them choose also, because nowadays patients are more educated and they want to be more implicated in this in the choice, as they also have changed. You mentioned, Karl, that we are changing with interventional glaucoma mindset. Well, the patients are changing also. They're becoming more educated, more willing to understand, and also wanting to choose more their surgery. And another history of another patient, a beautiful 60-year-old patient, but really, the woman that takes care of herself, that looks 20 years younger, the profile, and with moderate glaucoma that is getting worse. And back then, 6 years ago, I proposed the Zen, and I was very happy. And this time I communicated correctly with those expectations. She was mildly happy despite having very good pressure, very good vision, because she had a feeling of foreign body sensation, and she thought it was the implant. And now that we had the Elios for her second eye, later on, when she developed a cataract, I proposed with the Elios implantless, and she's very happy. So it's interesting to know that patients are choosing more. Their mindset is changing. They're also getting more focused on their own quality of life. And we do need to adapt to everyone's profile and understand what is understand the expectations, and explain what are the expectations also that they can have within the different treatments. And one point that I liked hearing from Jose is that sometimes patients are so well after surgery, these new surgeries, that they forget they have glaucoma. We need to remind them they do need to have a follow-up. In terms of expectations, to answer more specifically to you, Gok, we have different outcomes that we want. So either we want to improve their tolerability with their eye drops, meaning we want to decrease the number of classes that they want, or we want to decrease IOP, or both. We have to adapt to the profile of the patient and the profile of the optic nerve.
Yeah, no, excellent points. Karl,
following on what Anna's just said, but also Jose. So we know we find ourselves kind of feeling as though we're psychologists sometimes in our glaucoma clinics, right? And what Anna's just reminded me now is you kind of have to delve into that patient to see what they really want. How you communicate it to them and what your aim is might be completely different. What you might want might be different, even though the same procedure might give me the same result. So this is really important. And I really do think that the psychology, Jose, you're absolutely right, is so important in our clinics. I even thought of getting a psychologist once, at least once, to deal with these things, because don't forget, also, these patients are with us for life, probably. And as Anna's saying, you need to follow them up. You do an Elios laser, they think they're cured. They still need to come back for follow-up. And the other thing I think, Jose, which I find really useful with the psychology, is showing them stuff. Because nowadays we have so much in terms of imaging. We can show them their OCT and show that after a procedure they're not progressing. People like looking at, for example, their IOP profiles, not just one measurement, but also how their pressure has remained stable since having a procedure. Sometimes I compare two eyes. So sometimes we have weekend profiles, we call them here in Germany, just showing them that profile is so strong sometimes to convince them to go ahead with the second eye. So really, really good points you've mentioned here, and the psychology of it is tough.
Yeah, no, awesome points, Carl. Again, a asymptomatic condition for a majority of our patients, trying to explain, educate, get them on the same wavelength as us is so important, right? I think as glaucoma specialists, we have to be able to profile our patients very quickly, particularly for new patients. Once surgeon and patient are on the same wavelength, then that's where, you build that trust. These patients are with us till surgeon or patient is no longer with us. These are lifelong patients. Um, Jose, what do you do in the scenario where you feel a patient needs a glaucoma intervention? Let's say a filtering surgery, a fairly major glaucoma intervention, but they themselves are completely asymptomatic, both vision wise and symptom wise. How do you navigate that difference in their expectations versus what you feel they need?
It's a difficult issue because, as you said, glaucoma is a silent disease. Those patients that come to our clinics, they have to trust that you're giving him or her a good advice to have a surgery in which they can lose vision. I think for our job as doctors is to explain the patient the consequences of not doing anything when there is let's say a glaucoma that is not under control, there is progression, the IOP is not under control. The patient is happy because he or she is not having any symptoms at all. He's doing his normal life, going to work, spending time with his kids, and doing sports. And then you're telling them that if we're not doing surgery, they're going to become blind because the pressure is in the high teens. And in those cases, I think it's a matter of psychology. You need to spend time with the patient. I never try to force the patient to have the surgery. I just try to explain them, even to offer them to get a second opinion in case they are still having doubts. And of course, it's very important to show them all the tests that are telling you that this is something very, very severe, visual fields, OCT, everything that is proving that there is a damage that is still not causing worse vision. You have to get the trust of your patient. You need to give him or her time and to reflect about the conversation you've had in the clinic. And this decision has to be taken together. It has to be a combined decision between your patient and you. I will never try to convince a patient to do something that he's not willing to do. That we have to get like an agreement, a clinical agreement.
And I think you're completely right, Jose. For a good proportion of our glaucoma patients, we do have a bit of time. We do have the chance for them to go home, sleep on it, come back a week or two later, allow those emotions, those thoughts to percolate through. And I think that's a really good point, that just because our clinics are packed, it's sometimes unreasonable for us to expect them to be able to process major life decisions within the space of a few minutes. So that's a really good tip. Anything else, Anna? Any tips or tricks for when there's a discrepancy between what patient wants or expects versus what may be needed medically?
Exactly. So I really love those points from Jose. I agree. glaucoma is silent. So the patient sometimes he just needs some time, and he needs our time also, and our knowledge. We can show them the damage in our exams. I like to show them the little line getting down and explain them, but I don't force the decision because it's such an overwhelming decision to have. So I give a medical recommendation, but I let them choose. However, I do state that I'm going to write my recommendation in the file, and there are risks in choosing, and there are risks in not advancing with the intervention, because there are risks in waiting, and we need to act. And more and more, since we have less in invasive surgeries, we have less risks. So we don't need to progress too much. We don't need to wait for too much damage, but we can wait for the patient to be convinced and especially ready for him. Sometimes also I may give a letter to the general doctor. This sometimes may help, and sometimes I give a letter. I write my recommendation, I write a report with my recommendation, and give the patient some time to read and rethink. And once more, I explain what are the alternatives, what is my recommendation, that we have less invasive alternatives, and I would usually give them this, or this would be probably the most likely for you to work with the less risk and a stepwise approach. But I respect the patient and give him some time. As Gok said, usually have some time. One final point is under promise and over deliver. Glaucoma is silent, so despite us explaining benefits and risks of every surgery, I do tend to give them less. I don't say you're going to see better because I'm going to associate cataract. I say I increase the probability of you improving with a cataract because your cataract is visually significant. And usually this gives us a good surprise, good recovery, and patients are much happier this way.
Yeah, I think, Carl, is there a risk? Obviously, we have so many glaucoma surgeries available to us now. Is there a risk of information overload, that we give them too many options as the surgeon, or should the patients know all the options in order to make a patient-centered choice?
Yeah, so it's playing psychologist again and trying to perceive what kind of patient you're facing. But I agree. I think the problem is more for us because there's so much to choose from. And I think it has to be clear in your mind, the algorithms we all have, they're all slightly different, yes. But I would hope that most of us have a clear idea of what to do when. And therefore, even though you know there might be 5 different procedures for this patient, you would probably not go through every single one, or you would emphasize the one that you think is more important or necessary or useful in that patient. I think one thing that Jose said struck me as well, about maybe sending the patient for a second opinion or bringing them back again, because some people think this is, counterintuitive. It means more clinic appointments and you're wasting time. But I do it as well, Jose. And I think it's so important. Actually, it saves time because you could spend an hour in the clinic explaining 10 different procedures, Gok, and the patient is just more and more confused. Because I think the first time you mention surgery, they all have a little bit of a shock to some degree.
Yeah.
So actually, if you cut that down and send them away to think about what you think are the prime procedures needed, and then you bring them back later, you're not just saving time in that clinic, then the patient's mind is clearer. You are more clear in your head because you've had also time to sort of reassess. You have a second fresh view. And you save time on the day of surgery, because how many times do perhaps your juniors list someone without telling you, or even your less junior colleagues, and then you see them on the day and the patient has 20 questions just before you're starting a list of 15 cases. So I really think that that's important. And the second opinion if needed as well. So luckily with most glaucoma cases, you can wait that little bit, and I think it's really worth it. But yes, we have a lot of choice nowadays, and therefore our job is a little bit more difficult. Yes, it's also quite exciting that you can individualize treatment to your particular patient. As Anna said, sort of someone might come to you specifically saying, I don't want an implant, and then you can give them that. Whereas with other people, they might need, filtering surgery because they have very advanced glaucoma. So choice is good, makes our life a bit more difficult, but also enables us to hopefully individualize treatment.
I think a lot of the same themes are coming back again about, psychology, communication, understanding the patients, the rapport. Jose, tough question, but in 1 or 2 sentences, what is not a good profile for a patient undergoing glaucoma surgery? What would spring red flags in a patient?
I think that I had that patient last week, and it was a patient that came with a lot of information from internet, ChatGPT, other doctors, and he knew everything beforehand. And he was somehow telling me what to do.
Mm.
He had the whole menu of things that could be done for him, and he was saying, "I want this," before even I saw him.
There's a difference between being researched, well informed, and then having preconceived ideas, isn't there? Yeah.
That's correct. And I talked with him, and I told him that I was very happy to treat him, but I needed to do a good assessment. Second, I needed to explain him the choices that he had, and then we'll probably decide together what to do next. But the way that he was focusing the problem to me, and he was trying to induce me to a treatment, to be honest, I didn't like that at all.
How long
Finally,
did that consultation take?
I received an email from him that was yesterday or the day before yesterday, saying that he was going to have the treatment elsewhere. So yeah, that was fair enough.
That was a clever move, referring to Anna. So that's Anna. So
yes,
this patient has now come to your clinic, and he's brought his twin brother. What other characteristics of the twin brother are there that make you think red flags?
This is also important, and once more, psychology. Psychology is so fundamental, because although we're shifting into making patient participate into the choice, we also need to maintain the medical knowledge and recommendation. So we need the patient to trust us. So if the patient does not trust us, this is a huge red flag, and we need to take time to explain and convince until he does, or refer to someone else and give him time to think.
What makes you think
trust is fundamental?
What makes you think the patient doesn't trust you?
Exactly.
What makes you think? What sort of cues would you have?
What are the cues for a patient not trusting me? As Jose said, when he wants to impose the treatment, the patient may ask many questions, but you can see in his non-verbal language that he's going back and really not wanting to understand what our recommendation is. Or number 3, patient doesn't care and he says he won't do anything. Or number 4, the patient says, yes, I'll do everything, but and sometimes the patient's wives gives us clues, and that they won't do anything. So non-verbal communication is very important also, as it is for us. The patient needs to know that we're really invested into preventing their loss of sight. They're investing into saving their vision.
Yeah. So you've done the smart thing, Anna. You've asked for a tertiary opinion from Karl. So Karl, this patient of Jose has come now with his twin brother, but he's also brought his wife, who's a medical defense lawyer, along as well. And they've come for a tertiary opinion from you. What else are you thinking?
So this is real life, isn't it? So what I would
It
first,
is.
so well, yeah.
Yeah.
So
You always ask the partner what they do for a living because they always know.
Absolutely, yes. And real life is that the partner doesn't have glaucoma and doesn't need surgery. So the one patient I wouldn't do surgery on is someone who doesn't need it. So first of all, you want to make sure that whether they need a treatment at all. Then the other patient where I wouldn't personally want to operate on is exactly Jose's patient, who's been to Anna as well, and has also been to 4 other glaucoma specialists in the last few months. And we see these patients.
Yeah.
And if I see that someone's already been fishing and shopping around, looking for whatever treatment they might want, etc., these are the red flags for me. And I do see quite a few of them. Somehow in Germany, it's really easy to get sort of referred to various places. And I really am strict with these people and try my best not to be the one who then accepts what they really want, because I truly believe it's not what they need, of course. And finally, the other patient where, of course, I wouldn't operate are those who are absolutely not engaged in the treatment you offer them or in any treatment at all. Because in the end, Anna's right about sort of the patients need to trust you, but sometimes it's not really just trust. It's about patients not understanding what's going on, maybe because they're old, maybe because they have dementia. And in the end, we need to remember that it's their own life and it's their own choice. And I think that's crucial.
Yeah, and I think one of the things you learn as you get more experienced is it's probably even more important to know who not to operate on than who to operate
Exactly.
on.
Absolutely.
Definitely.
Completely
Yeah.
agree.
Guys, the time has flown by. It's been a really deep conversation. Tough questions. Thank you for letting me go off script, as you probably knew I would do, and just go with the flow. But I think it gives the viewers and the listeners really, a true perspective on where we are with happy patients, unhappy patients, quality of life. It's a really interesting time as a glaucoma surgeon now because we are more interventional, we are more surgical than we ever have been before. But the nature of the disease, the nature of the condition, the longevity of our relationships with our patients, one theme that has come through again and again is the communication, the rapport, the psychology. And I think, only once you have those fundamentals in place as a glaucoma surgeon can you then understand your patient fully and work with them to achieve stability in their disease, and also hopefully along the way give them as much quality of life and happiness. So I think on that note, the glaucoma surgeons, we know we have to be skilled, but I think as it's come across, I think we also have to be advocates for our patients and probably have a degree in psychology as well. So thank you everyone for tuning in to a very deep and insightful episode of interventional glaucoma. Thank you, Karl, Jose, and Anna, for your time. It's a shame we couldn't do this in
Thank you.
person and kiss that lovely bald head of Karl's, but we'll have to do that next time.
Anytime,
Thank you.
go.
Thank you for Elios for sponsoring this and allowing us to talk. And for more information about this topic, please do read the show notes. Thank you, everyone. And until next time, keep well and keep looking after our patients. Make sure they're happy. Take care, guys.
Thank you. Thank you. Bye-bye.
Thank you.
Bye-bye.
Thank you for tuning into this episode of Interventional Glaucoma. Want to hear more? Be sure to click the subscribe button to be notified of new episodes. For more information about this episode's topic, read the show notes at eliosvision.com/OUS/podcast. The Elios system Bausch & Lomb is manufactured by MLase GmbH and by WEINERT Fibre Optics GmbH. Elios is CE marked for use in adult patients with glaucoma and is currently under investigational use in the US as part of an ongoing IDE study by the FDA. The ExTra 2 Laser Class 4 has the brand name Elios. The ExTra 2 is equivalent to ExTra and AIDA devices. Please refer to the full disclaimer in the show notes.